Good morning, everyone. Today, I would like to present to you our project on the topic of Montreal Cognitive Assessment and Mini Mental State Examination, cutoff points for mind cognitive impairment and dementia. I'm Jing Shang, and I will give you a brief introduction of our project. My group mate Zhen Wu will talk about the dataset and analysis procedures. Subsequently, Fear Han will speak to you the analysis results, and Yutong Zhang will conclude our work. This is the glossary of the abbreviations in this present. Just want to make our presentation more general and concise. Demographic aging is a worldwide process that shows the successes of improved healthcare over the last century. Many are now living longer and healthier lives, and so the world population has a great proportion of older people. Just to give you a rough idea, in 2030, it is estimated that there are 941.6 million people aged over 65 years old in the world, with compound annual growth rate is 2.6%. So why we choose this topic though? Well, we choose it as we notice that Alzheimer's disease is an emerging affliction of Asian population. Alzheimer's disease processes along a continuum with three phases: preclinical disease, mind cognitive impairment, and clinical apparent dementia. The increasing prevalence of MCI and dementia will result in increasing comorbidities, and even with comprehensive treatment, MCI and dementia can significantly impact both patients and caregivers' quality of life. As such, it is critical to diagnose cognitive impairment and prescribe interventions promptly. A good screen test can significantly improve the efficiency and accuracy of MCI and dementia diagnosis. The Mini Mental State Examination and the Montreal Cognitive Assessment are two commonly used cognitive function screen tools. Our study objectives are to examine MMSE and MoCA performance in detecting cognitive impairment, and the second one is to identify and recommend optimal cutoff points of MMSE and MoCA for self-diagnosis and screening of cognitive impairment status.
Let me introduce the method we use in this research. We adopted the data from ISCC database, which maintain large standard clinical datasets to explore Alzheimer's disease. The dataset used in this analysis was published in December 2020. Study subjects have to meet the following inclusion criteria to be included in this analysis. Firstly, subjects have to complete a valid MSE or MoCA test. Secondly, age was between 61 and 90 years. We excluded subjects who was younger than 60 or older than 90 years due to extremely small sample sizes. Subjects receive cognitive status examination by clinicians and pre-specified criteria for MCI and all-cause dementia. Cognitive status were 4 stages: normal, cognitive impaired, MCI, or dementia. Age was categorized into 3 groups based on 10 years interval, and the years of education was categorized into 4 levels: high school degree or below, and some college or bachelor degree, graduate school or master degree, and doctorate or above. 3 binary cognitive status variables were created. The first one is normal vs cognitive impaired, MCI, or dementia. The second one is normal cognitive impaired vs MCI or dementia. The second one is normal cognitive impaired or MCI with dementia. Due to a large amount of missing data in other clinical variables, age, sex, and years of education was selected from 24 subgroups for cutoff point investigation. Logistic regression and the receiver operating characteristics curve were employed to assess association between scores of MSE and MoCA and cognitive status based on age, sex, and education level. We compare the change in the area under the ROC curve before and after adding MSE or MOCA or MoCA on the model with age, sex, and education owning. The optimal cutoff point was estimated by maximizing the Uden index and minimizing the distance to 0.1 point of the ROC curve. If the maximum Uden index and minimum distance indicate different cutoff points, we chose the one with the higher sensitivity. Macro was applied to efficiently replace the analyze and calculate the optimal cutoff points for different subgroups.
Hello everyone, my name is Fair and I'm going to introduce a part of results and visualization. If we look at our first table, which is the summary statistic of our study subjects, you could see that around 120 subjects were included, and almost half of them had been diagnosed as normal cognitive status, while only 5% of them had been diagnosed as cognitive impaired but didn't meet the criteria for MCI. About 20% of them had MCI and 30% with dementia. The sample size for subjects who took MMSE and the MoCA test were around 100,000 and 30,000 respectively. What to be noticed is that the mean score for both MMSE and the MoCA in subjects with dementia appeared to be significantly different from those with other cognitive stages. And if you look at the bottom lines, you can see the reason why we exclude diabetes, smoking history, alcohol abuse, hypertension, and hypercholesteremia from our subgroup stratification, because only very limited numbers of subjects had available information regarding to those. So here comes to our second table, which are comparisons between models with only age, education, and sex, and the models after adding MMSE or MoCA. What to be noticed here are the three different binary outcome variables, which were created as Roman number 1, 2, and 3. So here, the Roman number 1 denotes normal cognitive status, whereas cognitive impaired, MCI, or dementia status. And 6 and 2 denotes the normal or cognitive impaired, whereas MCI or dementia. And the 3 denotes normal cognitive impaired or MCI, whereas dementia. So here we could see that after adding MSE, the AUC, which areas under curve, increased by around 23 to 31%, which were considered as clinical significant. The most substantial increase in AOC after adding MCE or MoCA was for the outcome 3, which MCI versus dementia. Our third table is the overview of the performance of MMSE and MoCA for different cognitive stages in subgroups based on age, sex, and education years. Overall, we could see that MMSE tends to have higher specificity, while MoCA tends to have higher sensitivity. So what to be noticed is that when focusing on dementia diagnosis, we could see that the sensitivity and the specificity achieve highest value for both MMSE and the MoCA test. Here comes to our first table, which is also the last one, and also the final results of our study, which shows optimal cutoff point of MMSE and the MoCA test for each subgroups that defined by age, sex, and education level. The difference in optimal cutoff points between cognitive impairment diagnosis and MCI diagnosis appeared to be negligible, which are the first and the second numbers in each cell. We could see that most of them are actually the same, whereas the difference were significant for dementia diagnosis, which are the third numbers in each cells. So when we look at the MMSE test, we could see the optimal cutoff points were different between the education levels that below and above high school, but the differences across age and sex were minimum. And for the MoCA test, the optimal cutoff point exhibit little difference between females and males. While on the other hand, the optimal cutoff points appear to be affected by age and education levels. So overall, that MoCA test seems to be more sensitive to the different characteristics of the subject than the MMSE test.
Hello everyone, this is Yutong Zhang, and I will talk about the conclusion and generalization. The study findings suggest the necessity of applying personalized cutoff point in MMSE and MoCA test. On top of age, sex, and education, both MMSE and MoCA are extremely helpful in testing cognitive status based on the substantial change in AUC. The sensitivity and the specificity of the two tests can vary depending on subjects' characteristics. Thus, using a personalized test cutoff may be more effective in diagnosis of cognitive function than a single universal cutoff. This test demonstrated the greatest increase in AUC, sensitivity, and specificity for the outcome of dementia, indicating that they may be more useful for dementia than impaired cognitive function or MCI. What's more, most of the cutoff points are similar for diagnosing impaired and MCI, suggesting that this test may serve as a more efficient diagnosing tool for dementia. Finally, let us talk about the comparison of previous studies and suggestion for the future works. Although Tan and other researchers have studied a similar topic, they chose Chinese or Singapore people as their interested population, while we focused on Americans. We used the same database as Chapman's work. Our study considered age, education, and sex as covariate and created subgroups, rather than separate analysis. They treated MCI and dementia as two distinct diseases, while we considered impaired MCI and dementia as an ordinal variable, although three separate binary variables were used in our analysis. However, there are some limitations of our works. First, only one of our study subjects has both MMSE and MoCA data. The increases in AUC are not directly comparable between the two tests. Future studies may wish to further investigate the performance of MoCA and MMSE in diagnosing cognitive impairment and dementia across subgroups, in the general population. Second, depression was not considered in our analysis. Depression could usually coexist with AD and may even accelerate the course of AD. The manifestation of depression could often be confused with early performance of dementia, which may cause difficulty in diagnosing dementia from depression. Since the depression was not mentioned in our dataset, we didn't consider or exclude those with depression in our analysis. Lastly, due to a relatively small group with impaired cognitive function, our results shows difficulty of MMSE or MoCA in diagnosing impaired. Future studies may wish to recruit more participants with impaired cognitive function.
Thank you everyone for your listening. If you have any question, please feel free to contact any of our team members. And also, I'm on behalf of my team to acknowledge the support from NACC and Dr. Cole for being an advisor. Her valuable and constructive suggestions have been very much appreciated.